Well, thank you so much, Pete. Thank you so much, Respiratory Associates, as well as Radiometer, for having me here today to be able to participate with this lecture. It's always nice to be back during Respiratory Care Week, which, speaking of that, can I say to the, what do we have here, 261 and still climbing people in the room, happy Respiratory Care Week. The work you do is important. And we have a lot of work to continue to do to grow this wonderful field that has led me to uh, uh, a wonderful life, just like it has for many of you. So I just want to celebrate you today on this final day. I guess tomorrow is actually the official final day, but the final Friday of Respiratory Care Week. And I hope you use the excitement and energy from this week to fuel you into the next 51 weeks until we get to celebrate it again next year. So happy Respiratory Care Week. The topic of today is hyperoxic acute lung injury. And I've added up here the artist formerly known as oxygen toxicity. Now, I'd like to say that I took credit for that. I did take credit for the artist part, try to throw a Prince reference in there. But I'm also going to be referencing today Egan's. This is the 12th edition. And I'm going to reference it often because it's got some really good gems in here. This is coming out of the 42nd chapter of this book. And this section of this starts off with hyperoxic acute lung injury. The condition formerly known as oxygen toxicity is currently termed hyperoxic acute lung injury. Now, if you didn't know that, it's okay, because I only found out about it about a year ago. And I was like, wow, I didn't even realize that. So we realized they're changing names on us and we don't even know, right? So that's what we're going to be talking about. Here's our objectives. We're going to identify the hazards associated with oxygen therapy. We're going to discuss the importance of appropriate oxygen titration. And then we're going to look at some evidence and compare the hazards associated with hypoxemia versus hyperoxemia. And even in one study, we'll even look at normoxemia. So those are our objectives. Now, before we get into this, we're going to do a little pop quiz. They're going to use the chat feature to tell me what you think the answer to this is. But this is Miss Jones. She's a 68-year-old COPD patient. She wears a 3-liter nasal cannula. She wears 3 liters per minute of oxygen via nasal cannula, and her daily maintenance medication regimen includes Duaneb Q4 and Symbicort BID. Now, this is a bonus question that I used to ask my students when I taught pharmacology. And the question is how many drugs is Miss Jones receiving or being administered? So I've got 3, 3, 3, 4, 4, 4, 4, 3, 3, 3, 3, 5. John Enos, that's the correct answer. And I'm going to tell you why. We see here that we have Symbicort right here. There's 2 drugs in Symbicort. So we know that, right? Okay, dual drug. We also are receiving Duaneb, another 2 drugs. That's 4 drugs right there. That's also the most common answer I receive when asking this question. And everybody, especially in my class, slept on oxygen. And I don't know why. It's funny because it's one of the most basic elements of respiratory therapy that we learned. You go back to your respiratory therapy school and you remember this was one of the very first things you learned was oxygen therapy. And I think it's because it's one of the very first things we learned, and it's one of the most simple and basic elements of what we do, is that I think we sleep on the fact and sometimes forget that it is a drug. And I'm going to leave you with this question also for you to ponder as we go through this presentation, and even as you go out and work as an RT. I'm going to give you this question, and I want you to ask yourself occasionally. If oxygen is a drug, I am still looking for the answer to why it's not on the MAR. Why is there not a place for documentation on the MAR that allows us to show and demonstrate proper administration of a drug? We don't haphazardly throw any other drugs out at people without monitoring it and documenting it. So I'm curious if anybody has a common sense answer that I'm just missing. I'd love to know it, because I've been asking myself that question now for a while, It sometimes keeps me up at night. So yeah, don't forget and don't sleep on the fact that oxygen is indeed a drug and it's important. Now we know the indications of oxygen. There's primarily three indications. We're going to treat documented acute hypoxemia. We're going to treat the signs and symptoms of chronic hypoxemia, and then we're going to deliver it to administer and to decrease cardiopulmonary workload. And then, of course, we know carbon monoxide poisoning comes in there. Let's talk about the hazards for just a second. There's hazards of oxygen therapy. There's actually 5. We're not going to talk about fire hazards. That's a different story for a different day. I want to talk about the 4 hazards of oxygen therapy. So again, about quiz time, go ahead and put in, if you will, just one hazard of oxygen therapy. Whichever one you can remember, the first one that comes to mind, put it in the chat there. All right, so we have got tripping. Okay, I see you. Oxygen toxicity, which is what we're talking about. We got nitrogen washout. So nitrogen washout leads to a lot of things. It also leads to absorption atelectasis. That's 100%. If we give too much oxygen, we flush out and wash out all of the nitrogen, and we know we get atelectasis along with that, and then it turns into other things as well. I also saw somebody else knock out respiratory drive and COPD. If it's too high, that's exactly right. That's what we refer to as the depression of ventilation. Now, if you guys wanted to have some fun today, we could open up a conversation and talk about the hypoxic drive theory and how many of you still believe in that and want to argue back and forth on what that is. Because we know that there's some questions about depression of ventilation and what's the true cause of it. I'm not here to talk about that today, but if you want to dive into it, there's lots of good information out there about how it's really more related to VQ mismatch, alteration, and Haldane effect and those type of things. But nonetheless, depression of ventilation is a hazard. Now I'm looking for one more here. I'm just going to roll through here real quick and see if I see it. Supports combustion. That's fire 100%. ROP, that's the one I'm looking for right there. Retinopathy of prematurity. Now, when we look at these, I find it interesting because retinopathy of prematurity is for our premature babies, right? It's in the name, retinopathy of prematurity. We know this can cause vision problems and blindness. You walk into a neonatal unit, and as an adult therapist, I get nervous almost immediately because I'm like, wait a second, why we got this patient over here sitting 85%? And they're okay with that, and it's fine. When we think about depression of ventilation, it kind of takes us to the opposite side of things. It takes us to more of our geriatric population, our end-stage COPDers, our patients who live with that chronic hypercapnia, and we know that we find that we need to be diligent in treating those patients to avoid this. And we're pretty good at that too. Respiratory therapists are real good at going, patients got COPD. Why are we sat at 98%? Turn that oxygen down, right? We're okay. 88 to 92%. I'm golden right there. That's what we do. These last two, we don't know. I don't know if we think about them enough and often enough. Because what we know is that specifically the one we're talking about today, oxygen toxicity, I don't think I ever understood what it was, honestly. And I've been a respiratory therapist. I graduated in 2001, so 22 years now. And I can tell you for a fact that if you would have asked me, what is oxygen toxicity? I'd have said, well, that's when you give too much oxygen and it hurts the lungs. But I didn't understand it. And so that's the one we're going to be talking about today. Like I said, absorption atelectasis is another one. All of these are reasons that we should be keeping oxygen therapy and proper administration of it on the forefront of our mind. But it's the ones that are harder to identify that I think we end up maybe sleeping on a little bit. So we're going to focus today on oxygen toxicity, which again, you're going to hear me refer to it as hyperoxic acute lung injury. Okay. Now here's essentially what oxygen toxicity or hyperoxic acute lung injury is and how it happens. Okay. So it's an increase in your FiO2, which we know if we increase FiO2, we're likely to increase PaO2. Now, when this happens, what we get is an excessive amount of free radicals. Now, again, go back to my school. I said, what'd you say? I said a free radical. What is a free radical? When you think about it, things that by nature seem to be radical tend to carry a negative connotation with them. You don't hear a lot of things talking about radical that are good, right? And so that's exactly what happens is in enduring cellular metabolism of the oxygen, there's this free electron that gets left out. And this electron is not happy. It's I'm looking for a partner, and I'm going to steal a partner if I can find one. And when this is normally happening, it's okay. It's not a problem because it's always happening, but we're in a state of homeostasis. The problem is when excessive levels of oxygen are delivered and you get these excessive free radicals. Now, essentially what happens is the bad guys now outnumber the good guys, and it causes a problem. Well, what do I mean by causes a problem? Well, it leads to lung injury. Now, that is a broad statement, right? So we're going to narrow in on this portion right here. When we look at free radicals and we have an increase in our free radicals, it leads to lung injury through three primary mechanisms. One, we see damage to the pulmonary capillary endothelial. We're talking about the capillaries here. Also leads to damage to the alveolar endothelial cells, and they also excite the inflammatory cascade. And we understand this. We have come a long ways in our education and as a field as respiratory therapists, and we know that inflammation is a problem. It causes excessive mucus production. It can lead to bronchospasm. It can lead to alveolar wall damage and pulmonary capillary damage just alike. You know, if you'd have told me that and I just left it right there, I would go, you know, I get it, but I still don't know if I get it. And so we're going to now break this down one more level. Let's see what we look at here. We say destruction and damage to the pulmonary capillary endothelial and the alveolar epithelial cells and the inflammatory cascade. What we're really saying is this is what happens. You see, we have an increase in pulmonary edema, and some data and research refers to it as lung edema. We get alveolar flooding, which we know is going to wash out surfactant and lead to a higher risk of atelectasis. We also can get pulmonary hemorrhaging. And then this last one is the one that made my ears perk up the first time I read it. Collagen, elastin, and hyaline membrane deposits. That's interesting to me because as a student, when I heard hyaline membrane, I thought ARDS. That my mind immediately went to ARDS. That's the only thing I associated it with. Now, obviously that wasn't correct, but that's what I thought. And I know a lot of people taking their board exams right now. If there's any students in the room, thanks for being here. A lot of students right now, when they are going through their patho class, they talk about hyaline membrane deposits in the ARDS lecture. I started thinking about this and I was like, well, none of this sounds good. And so how do I know this is happening, right? Well, we know that there's going to be several signs and symptoms of this going on. Your patient is likely, due to the inflammatory process, is going to have an irritated airway, which might lead to coughing. They also might become short of breath, which is going to cause them most likely to be tachypnic. So you see all these things, but you're going, well, what's causing all of this? And then you get a chest x-ray, and your chest x-ray looks like that. Now, I don't know about you, but to me, if you put that x-ray in front of me, I would say that's ARDS. And here I am looking at a hyperoxic acute lung injury chest x-ray, and I can't help but to think to myself, and this is not a factual statement, what I'm about to say, but the thought enters my mind, how many patients have I taken care of like this that I thought I was taking care of ARDS, and we actually caused it? Maybe perhaps it was a hyperoxic acute lung injury. I can tell you with 100% confidence, I have never taken care of a patient in my entire respiratory therapy career where the diagnosis was hyperoxic acute lung injury, where that's where I knew we were treating. But I've taken care of thousands of these x-rays, and I'm sure you have too. So it makes me wonder, what is this something that we may be contributing to from a lack of focus and emphasis on proper oxygen administration? Now, this is basically what we're talking about. Excessive oxygen leads to oxygen toxicity or hyperoxic acute lung injury. We know based off of everything we just said, right? Go back 2 slides. And all of this happens: pulmonary edema, alveolar flooding, pulmonary hemorrhage, hyaline membrane deposits, collagen, elastin, all of those things happening inside the alveoli. Now, as respiratory therapists, we know that pulmonary edema and those things we just talked about are going to cause a shunt. So what is that going to do? Well, we know shunting is a reduction in our VQ mismatch, our VQ ratio, which is going to lead to hypoxemia. Our PaO2 is going to go down. And when that happens, commonly the answer is to increase FiO2, which just continues to exacerbate the problem. And so this is all, I don't know about you, but for me, this is all very, very intriguing stuff. It kind of blows my mind, to be honest with you, to look at it and to think, what it is. Now, before I go on any further, I want to talk a little bit about what Egan's defines as hyperoxia. So you're like, okay, well, what levels are we talking about here, right? When you're talking about these high PaO2s and stuff, what are we talking about? Well, Egan's initially talks about hyperoxia being defined, and it's defined through studies. And so all the studies that you can find, and believe me, you can find a lot of them, they're defining the hyperoxia. A lot of them use 300 millimeters per mercury as their marker that we're talking about. Now, I know if you're thinking like me, you're like, well, how often do we have somebody sitting above 300? Hopefully not very often. But it also goes down to show that there does appear to be a clinical importance at a PaO2s around 150 millimeters of mercury. So that's a big difference. Now it's not so far-fetched, right? And so what we know is that all of this is related to PaO2, higher PaO2s due to higher FiO2s, and then how long is it exposed, okay? The higher the PaO2, the longer the exposure, the greater the likelihood of damage. And that's straight out of Egan's. And that's what the cycle looks like. And so it's very interesting to me when we do this. So the question is if you were to recognize this, how would you treat it? And what would we do to treat it? Well, we're going to start, before we talk about management of it or treatment of it, we're going to talk about and understand that prevention is number one. Prevention is king here. Okay, so if we can focus on, like everything else, right? Like every other disease process, if we can focus on prevention, then the game gets a lot easier. Preventing it is important through the appropriate monitoring of your patient's oxygen status and the management of the therapy that's being given. Proper titration, recognizing that my patient currently right now doesn't need this much oxygen. That's the name of the game in preventing hyperoxic acute lung injury. Now, once the chest X-ray comes back and looks like that, now it gets a little harder. We're like, okay, what do we do now? Well, really, it just comes down to a lot of what we do with ARDS is just supportive care and lung protective ventilator strategies to get through the inflammatory process. But interesting enough, antioxidants, exogenous antioxidants, are also indicated for this, because remember, what it is you have these free radicals. And these free radicals are reactive oxygen species. They're oxidants. And they've now outnumbered the endogenous, our normal level of antioxidants in our body. And so if we can give antioxidants, like a vitamin C or a vitamin E would maybe be indicated here to help with this problem associated with this excessive amount of increased free radicals. And so we got to get those down. But that's primarily the treatment of it. It doesn't get a whole lot deeper than that. Again, prevention is key and probably where we would like to focus. Now, what I want to do is really dive into some numbers here and show you some of the evidence that's gone into hyperoxic acute lung injury. We could spend all day here and go through the hundreds and hundreds of works that have looked at this hyperoxic acute lung injury topic. I just pulled some that I thought had interesting things to me. And, we're going to hit all of our objectives today. But my goal here is really just to challenge you to think about this, to think about some of these things and go, how good are we in the facility where I work at preventing this and focusing on this, understanding that it's real. It's a real thing. So in 2017, Derlinger, they were just looking at hyperoxemia and how prevalent it was. And so what they found is that when the SpO2 was 100%, when SpO2 was 100%, 89% of the time, the PaO2 was greater than 100 millimeters of mercury. 85% of the time, the PaO2 was greater than 125 millimeters of mercury. That's what they found. Now, there's two things that I can walk into an ICU, either working or visiting, and I can typically identify two things in every ICU. One of them is flow asynchronies during mechanical ventilation. That's another conversation for another day. The second one is adult ICU patients sitting at 100% all the way around the unit. It's maybe it's not 100, maybe it's 99%. So don't. I know, we keep ours at 99. Okay, 99, 100. And I ask myself every time I see these, I go, I wonder what their PaO2 is, and I'm going to tell you why I asked that in just a second. They also found out that hyperoxemia was negligible. It was not a concern when SpO2s of 95 to 96% were targeted. Now, I've known this story in our orders and our working as a respiratory therapist. We know that Arsenet says 88 to 92%. We've got, other orders that say keep your patients, greater than 92. Some say 90 to 94. This is what this evidence showed, is that when SATs were held between 95 to 96, not a recommendation, just a fact, hyperoxemia wasn't a conversation. This was okay. Now the question is why? Why is 95 to 96 okay, but 100 is not? Well, it goes back to the oxyhemoglobin dissociation curve. And we have to also assume, that's a great point there, Jeff. Your comment there in the chat bar assumes SpO2 accuracy. 100%. There's always variables in all of this, and you're exactly right on that. Same with this. When you talk about, anytime you talk about the oxyhemoglobin dissociation curve, educators love to pull this out and talk about this. Anytime you talk about this, you're also assuming that we're talking from a balanced pH, from a state of normal pH balance. Okay, and so same concept here. But here's what we notice. If you remember, PaO2 is at the bottom, saturation is on the side. So the higher the PaO2, the higher the saturation. That's basically what this says. Here is 80. When we go up here, we cross over and come back. That's what that normal is. 95.8%, 96%, 95, 96. If I'm not mistaken, yep, that's what they found right there. Is that somebody satting, assuming correct pulse oximetry accuracy, 95 to 96% gives you're not worried about hyperoxemia. Why? Because we're sitting at about 80 millimeters of mercury. But here's the problem. Look how flat this gets going afterwards. It just flattens out. So when you come over here and somebody's sitting at 99% or 100% or 100% or 100%, well, we can't get 110%. So after we're fully saturated, it's always 100%. But this goes on forever. So how do I know if my patient's PaO2 is 95? How do I know if it's 105. How do I know if it's 155 or 355? You don't. Those saturations there don't really help you a lot from a clinical standpoint. As an expert at the bedside, there's not a lot of value in somebody satting 100%. And you know, it's interesting because you see this, and like I said, I assume most of us are RTs here today. You know, we see a patient satting 100%, and then something happens, and the saturation falls from 100% to 97%. And what do? We increase FiO2. Why? To get them back up to 100%, where 97 is still normal. It's still normoxemia, right? And so it's interesting because, you know, I really like thinking about this because I like to have a good idea of where my patient is from a PaO2 standpoint. I have a better idea somewhere around 95% than I do with my patient sitting at 100%. And then, of course, you get on back on this side of it and you know it falls off quickly, and you have somebody, you know, with a PaO2 of 55, they're probably somewhere more around in the high 80s, 86 to 88, somewhere around there. And so, you know, you can use this. It's very helpful right here, but on that flat push, it really loses a lot of clinical relevance from what I can see. And so what we're going to find is that going back to what this was saying, when they're 100% on that flat portion, your PaO2 is almost 90% of the time over 100. And we know the normal range for oxygen is 80 to 100 millimeters of mercury. So it's anything greater than that, and we're now entering in the realm of hyperoxemia, too much oxygen in the blood, which we now know is associated back again with these free radicals and potentially getting us to a point to where we're going to be causing harmful lung effects. This article came from 2016. It was Callet. His work said hyperoxia comes with an increased risk of pulmonary complications and mortality. Now, I read that the first time and I thought, wow, that's interesting, because we always obviously know the harmful and hazards of hypoxemia. We work real hard to combat that. But I don't know if I ever thought that I would think about hyperoxia coming with an increased risk for pulmonary complications and mortality until I really started understanding hyperoxic acute lung injury. So what they did was they said, what if you took a conservative oxygen strategy, okay, to avoid this from happening? What they said is if you target 90 and 92% with the lowest FiO2, here's what they found. At the end of it, there was a reduced risk for atelectasis. Now, atelectasis, again, absorption atelectasis, all that alveolar flooding. Obviously, it's going to be a complication of it. We don't always think about it being with oxygen in this case, but we reduced it to reduce the risk of atelectasis. They also found they had a reduced time to the first SBT, which is interesting because if we can get to the first SBT quicker, then there's a good chance we can get out of the hospital or get out of the ICU quicker, or at least off the vent quicker, which typically follows out of the ICU quicker, out of the hospital quicker. They also found it was safe and feasible. In other words, running a lowest FiO2 to get 92%. It was safe and feasible and also reduced the risk of hyperoxia, as well as avoiding risk associated with hypoxemia. So their study found that there was no significant risk that came with this approach. They also looked into practices, and they said, okay, how is the management side of oxygen therapy? So we know that clearly too much oxygen can be a bad thing. I think we've clarified that. But they also looked to see, well, what practice is happening at the bedside? And I think we can probably all relate to this. What they found is that the staff was pretty good at titrating when FiO2s are greater than 60%. Who agrees with that? Just say yes or no. If you've got somebody on 100, 90, 80, or 70, typically pretty good at effectively looking at that and going, yeah, let's get that down, right? And that's what the data shows too. Everybody says yes, 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 yes. But check this out. Not when the FiO2 is less than or equal to 40%. So now your patient, 35% O2, standing 100%. We turning it down? Yes or no? Right? So we think about this stuff, right? We found actually I missed the talk. I missed the talk that I really wanted to go to, and I wasn't able to attend it. But the title of the talk was 30 in regards to FiO2 is the new 40. So we have this idea that for a long time, remember you'd wean that FiO2 down to 40% and you would stay there, and then it was like that's as low as we go. Well, okay, but why? And they would say, well, because that's our protocol. We stop at 40. But again, I ask you why. What data supports that? And what harmful effects come from that? I wear a shirt here. Why greater than how? I know how to wean oxygen. It's more important to know why I should be and to ask those questions. Why are we stopping at 40? I'll ask you this. Why are we stopping at 30? Why are we stopping at 25? I see somebody here. We had a vented patient on 21%. And if there's no indication for oxygen, I think it's a great conversation to have to ask ourselves, why? Why is the patient on supplemental oxygen if we can achieve normal oxygenation at room air, even if they're requiring mechanical ventilation support? If we go back to the indications, I don't recall mechanical ventilation being one of them. And so I love the conversation, and I love to see the comments here on everyone gets stuck and they get below 50%. Yeah, we gotta work toward this and remind ourselves, why are we giving patients oxygen? Because it comes with effects. I liken it like this. If you had a patient who wasn't in pain, would we consider giving morphine? What's your pain scale? 0. No pain at all. Absolutely none. Cool, here's some morphine. Because that's as low as we go. It doesn't. We have to challenge this, right? And of course, it matters what they're on at home. That's right. If they're on that at home, then they're probably not getting down to 21% in the facility. So you're right. The home O2 matters also. This article came out in 2018. This was Paige. She said, and they found that mechanical ventilation patients in the ICU spend 70% of their time with an SpO2, 96 to 100%. The mean PaO2 was 144 millimeters of mercury. Remember what Egan said? Becomes clinically important greater than 150. If that's the mean, then we were definitely above that in some of these cases. So it's interesting to me. We also see that pre-ICU exposure to hyperoxia mortality. So what was happening before they get to the ICU? And this is an area I'm extremely passionate about. And what they found was that hyperoxia mortality, 29.7%. Normoxia, 19.4%. Higher mortality with hyperoxia when they were hyperoxygenated for extended time pre-ICU. Okay, now the timing of this, I'm sure was a longer time. It wasn't a quick come into the ER, you're there for 15, go to CAT scan up to the ICU. This was extended stays in the ER. And then they went on to say FiO2 greater than 90% with little titration in the ED. That means patients in the emergency room spend a lot of time at FiO2s greater than 90% with little titration. Because what do? We fix it when we get to the ICU. That's when it really starts, right? But we have to really talk about this, because I think perspective is so important. And I was talking to a couple of flight paramedics this past week, and they were talking to me about how they just bag a patient. We'll just bag a patient, right? They asked that. What they actually did was they asked me. They said, "Do you give me one tip, one thing that as an RT you would like to see me know or learn more about?" And I said, "Well, how much time do you have? And do you want it to be tangible, like something you can do tomorrow?" And she said, "Yes." And I said, "Perfect. Titrate your FiO2. Why are we bringing them in on 100%? They may be in a transport for 40 minutes, and then they get to the ER, they're on 100%, and then we sit in the ER for 2, 3, 4 hours on 100%. Okay. Now, the thing here is that we have to, as RTs, this is a place in the game where we can get a lot of ground if we'll become proactive in the ER in saying, you know what, let's normalize this PaO2 as soon as possible post intubation. That doesn't say post arrival to ER. It says post intubation, which is exactly the tip I gave to that one paramedic. Now, we all know we have lots of tips, but that's the one tip I gave to them that day because I think this is important. Now, for you as an RT and you work in the ER, it's interesting because you can't control what they're doing out there before they get to you. But once they get to you, you can. And so understanding that this excessively high FiO2 in the ED is associated with increased pulmonary complications, this is our wheelhouse. Take ownership in that, right? Shut this down and let's go. Let's get this weaning process going so we can get this patient to the oxygen level that they need, not to one that is just comfortable because we're about to take them to the ICU in a little bit of time. Now, it's interesting because I've been painting this picture for you that too much oxygen is bad. I'm gonna leave you with that. I don't want you to leave here thinking like, oh, hyperoxia is worse than hypoxemia, because that's not what I'm saying. Okay, just giving you a little bit of insight into some data here to challenge you to think about this and how you can take it and apply it to your practice, because this study says the exact opposite. We've been looking at these higher risk for mortality, higher risk for complications with hyperoxia. Well, this one says, this is in 2023, they looked at patients that were expected to be on mechanical ventilation for greater than 24 hours. And that was what it was. So there's a large portion of the patients that might have been excluded. Everybody in this was like, okay, this person is going to be on the vent longer than 24 hours. What they did was they did two different strategies. They had a low oxygenation target where they targeted 55 to 80 millimeters of mercury. Okay, so somewhere around 88 to 95%. Then they had another group where they targeted high oxygenation targets, where they targeted 110 to 150 millimeters of mercury. They looked at mortality, ICU length of stay, hospital length of stay, and vent-free days. No change, no difference. And as a matter of fact, on the mortality, the hyperoxygenated one actually trended more towards almost having a statistical difference, but it didn't happen. So their study was actually in contrast to other studies that are out there that have shown the effects of too much oxygen being related to mortality. I think like everything we do here, it gets very it's very easy to try to narrow it down to one thing. There's so many variables in this. Obviously, somebody who requires a higher FiO2 is probably sicker. And so the fact that they probably come with a higher risk for mortality. So there's so many different variables in this. And that's what all of these articles and research data, it all says the same thing. And that is that, yeah, but we still need to continue to study, and we still need to continue to pay attention to this. And what I say is essentially what I feel like what Egan says here. And I think what they say is, they say it best right here when they say, rather than applying strict cutoffs, which is what we're hearing over here in the chat, it's a lot of talk like this low, different stuff. Rather than applying strict cutoffs, the goal always should be to use the lowest possible FiO2 to achieve adequate tissue oxygenation. I think that's the message, is understanding that oxygen comes with hazards. Too much is a bad thing. Too little is a bad thing. So one of the articles actually stated, it said, It goes back to the discovery of oxygen. It's been known that it is a friend and a foe. And so we realize that our job is to identify the appropriate amount and to not sleep on the idea that there's no hazards that come with too much. I also think it's important to note here, especially here where we're talking about, okay, what are we targeting? Oxygen therapy in general is something that we can really take and own as an expert and as a field. I know we're busy doing treatments and vent assessments and this and that, but you get that call to come take a look at this patient who maybe was on an O2, maybe a 2-liter cannula at 2 liters, okay? And they've been satting 95% all day long. And you get that call when you're at breakfast during RT week watching a webinar. They're like, hey, your patient is desatting. They're 87%. Just FYI, I bumped them up to 3. We come take a look at them when you get a chance. You go up there, you take a look at them. Now they're on 3 and they're satting 88%. And what do? We bump it up to 4. Maybe we bump it up to 5. Maybe put a bulb humidifier. What I think the bigger thing there is us as experts have to ask ourselves and go, wait a second. I want to know why my patient is needing more oxygen right now. What has happened from a physiology standpoint? What's going on here? And dive deeper into maybe an X-ray is indicated, maybe lung ultrasound. Great tool, right? With lots of value that can quickly be utilized to help dive deeper into this problem to identify why the patient needs more oxygen instead of just giving them more. Just want you to consider that as we get close to wrapping this up. Here's my summary. Number one, remember, oxygen is a drug. We cannot forget that. Also remember that diligent, which is what we said here, diligent administration and appropriate titration should be considered for all patients. All patients, not just retinopathy of prematurity, not just the little babies where we're super good at that, and not just the COPDers where we're super good at that, but every single patient that comes in that is receiving a drug, the drug known as oxygen, we need to be diligent in our administration of that. Egan's also states this, and this is very, very key, because sometimes when you start talking to people about the hazards and the effects of oxygen that come with too much, they start getting scared to give any of it at all. Like, well, I don't want to give too much, so I'm not going to give any. That's not the message here, and that's not what should be taken away from this. Egan says, regardless of approach, supplemental oxygen never should be withheld from hypoxemic patients. Straight out of Egan's, didn't make that up. That's what they're saying. So it's important. This is good stuff. Also, I have one more sentence for you here, kind of leave you with a final thought. And this final thought is quoted out of a mock from 2011. It says, understanding precise mechanisms of injury and pulmonary cellular responses to hyperoxia is essential evidence for expert practice. This is the word I want to read. This is why I put this in here. Expert practice. I think a lot of words there. I had to read it a couple of times when I read it. Let me read this again. Understanding precise mechanisms of injury, pulmonary cellular responses, hyperoxia is essential. And this is what I want to leave you with. And this is what I want to tell you. That's a true statement. You're the only people, you in your room when you're there as a registered respiratory therapist, the only one that's going to be thinking about this. It's your expertise to own, and you have to own it. You have to want to own it, because when you do, it will lead to better care for your patients. And we know at the end of the day, they deserve the very, very best. And it's our job to be that for them, to advocate for them, to make those arguments, in this situation. So I want to say thank you to everybody here. I want to say thank you to Radiometer for sponsoring this talk. They do a great job in spreading education and supporting education out and amongst the respiratory therapy community. So thank you, Radiometer. And again, thank you, Respiratory Associates, for having me back now for, I think it's the 3rd consecutive year during Respiratory Care Week to do this lecture. I'm always so honored to be here. You can go ahead and put any questions you have in the chat, and I will answer them for you. While you do that, this is where you can find me. You can find me on YouTube, Respiratory Coach, on Instagram, @Respiratory Coach. TikTok, respiratory coach, LinkedIn at Joe Lewis. I'm a big fan of LinkedIn right now. It's got a lot of good stuff going on, make a lot of good professional relationships and connections on there. So if you don't have a LinkedIn, I highly encourage you to go get one and connect with me, please. And then you can always send me email, respiratorycoach@gmail.com. I would love to converse with you and have an ongoing conversation however we can.